Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody in Arab countries. Good morning or good afternoon, Prof. Elizabeth. My name is Nasser Al-Johani, consultant endocrinologist and the president of Arab Thyroid Association. I want to thank all of participants really in attending this very interesting Arab Thyroid Association webinar. And really, it is our pleasure to welcome two eminent speakers. We have two presentations today for around, with discussion for around 1 hour and 15 minutes. It is my pleasure on behalf of Arab Thyroid Association directors to present Prof. Elizabeth Beers. She is a professor of medicine and endocrine fellowship program in Boston University School of Medicine in USA. All of us know Prof. Elizabeth. She is the past president of American Thyroid Association, and she's actually participating actively in the formulations of the American Thyroid Association guidelines. She will talk about very important subject, really, management of thyroid disease in a pregnancy, especially hyperthyroidism is not easy. So we need some expert like Elizabeth. She have many publications and she have many book chapters and many awards. Really, it is our pleasure to introduce Elizabeth. Welcome, Elizabeth. She will talk about management of thyroid disease in the pregnancy. We'll not forget the organizing company ICOM and also the sponsor that actively participating with the Arab Thyroid Association, Horizon Company. Welcome, Prof. Elizabeth.
Thank you. It's a pleasure to be here. Give me just a moment and I'll share my slides. Can you see that okay?
Yes.
Perfect. So I've been asked to talk about thyroid disorders in pregnancy today. And I'd like to start by just quickly reviewing how to interpret thyroid function testing in pregnancy and how we should really be thinking about thyroid, the assessment of thyroid hormone during gestation. And then I'll talk a little bit about both the diagnosis and the management of both hypo and hyperthyroidism in pregnant women. So to start with, it's important to remember always that thyroid function changes across the course of gestation. And one of the major drivers of that change is HCG. So recall that human chorionic gonadotrophin levels rise in the serum till about week 10 or 12 of gestation, and then they start to decline again. And because HCG stimulates the thyroidal TSH receptor, when there's a lot of HCG around, that will tend to drive an increase in thyroid hormone production, and that increased circulating thyroid hormone will feed back at the pituitary and cause a concomitant decline in TSH. So therefore, the upshot is that in early pregnancy, when those HCG levels are highest, we may see a slight decrease in TSH. Now, just what a normal TSH is in pregnancy has been a bit controversial in recent years, but most recently, there's fairly good concordance in guidelines. And the recommendation is that for most of us who do not have kind of optimally derived trimester-specific, assay-specific, and population-specific pregnancy reference ranges for these labs, that it is reasonable to use an upper limit for TSH of about 4 in early pregnancy. Now, before we think about how to manage thyroid dysfunction in pregnant women, it's also important to take a moment to think about what does and does not cross the placenta from mother to fetus. So the maternal TSH and HCG do not cross. Maternal thyroid hormone does at low but very critical levels. The fetus has a thyroid that's formed by about 10 to 12 weeks of gestation, but that fetal thyroid does not really start to function until week 16 to 20. So in the first half of pregnancy, the fetus is really utterly reliant on that maternal thyroid hormone that does cross the placenta. And then finally, the maternal thyroid antibodies cross the placenta. Iodine does, which is important for the fetal thyroid hormone production in the second half of pregnancy. And as we'll talk about also, the anti-thyroid drugs do cross to the fetus. So to jump in and think a little bit about hypothyroidism in pregnancy, overt hypothyroidism, where TSH is elevated and the free T4 levels are low, is not controversial at all. Always when we see significant degrees of hypothyroidism in pregnancy, that needs to be treated, because we know that untreated pregnant women are going to be at increased risk for gestational hypertension, for pregnancy loss, preterm delivery, infants with low birth weight, and also because of the importance of that maternal thyroid hormone for fetal brain development. Women with untreated overt hypothyroidism have children at risk for having lower IQ. What has been much more challenging to understand, though, is whether we need to be treating women with milder degrees of thyroid hypofunction in the gestational setting. And there's now a literature that goes back about 20 years that has looked quite extensively at associations of maternal subclinical hypothyroidism and a whole host of different obstetric outcomes. As of 2016, when we last formulated the American Thyroid Association pregnancy guidelines, this was really the state of the science. And in this pooled analysis from Spiro de la Maraca and colleagues, we could see that maternal subclinical hypothyroidism in pregnancy was associated with increased risk for pregnancy loss, for placental abruption, for preterm rupture of membranes, and for neonatal death. Now, since then, this literature has continued to grow. There are lots of new studies. One of the newer developments in this area is the development of an international thyroid consortium. I'm part of what's quite a large group now, where we have data from cohorts that combined include almost 50,000 mother-child pairs. And we are now starting to be able to use these data sets to do individual participant level meta-analyses. And the first analysis that we published from this consortium was in JAMA in 2019. Here we looked at the association of mild degrees of maternal thyroid hypofunction on increased risk for preterm delivery. And we saw that subclinical hypothyroidism in the mother did seem to increase that risk for preterm delivery. We also looked at an entity known as isolated maternal hypothyroxanemia, which is kind of a funny thing that we only really define in the pregnancy setting. And that is going to be a woman with a normal serum TSH, pregnancy appropriate serum TSH, but a free T4 level that's in the bottom 2.5 percentile for a given cohort. So those women with the low TSH, with the normal TSH and the low free T4, also in this consortium analysis were at increased risk for preterm birth. Now, something that we saw in the consortium analyses and something that has been seen really quite consistently across this literature is that there seems to be something additive or synergistic about having both a TSH elevation in pregnancy and also having positive TPO antibodies. And I think that's nicely demonstrated by this Chinese cohort study, where they took women in early gestation and they stratified based both on the serum TSH level and also on the presence or absence of thyroid antibodies. The primary outcome they looked at in this analysis was miscarriage. And what we can see in the top line is that women with high normal TSHs, the TSHs in the range of 2.5 to 5, without thyroid antibodies, were not at increased risk for miscarriage compared to women where the TSH was less than 2.5. But the women where the TSH was truly elevated in the range of 5 to 10, when the antibodies were negative, risk for miscarriage goes up. In women who are TPO antibody positive but have fully normal thyroid function, there is also increased risk for miscarriage. And I won't have time to talk about that today, but certainly happy to entertain questions about that afterwards. The biggest risk for miscarriage, though, is when women have both high TSH and the TPO antibodies. So when that TSH was high normal, 2.5 to 5, but the antibodies are positive, the odds ratio for miscarriage goes up to about 5. And the risk is highest, it doubles to almost 10 when the TSH is truly elevated, 5 to 10, and those antibodies are also positive. So we don't actually know why that is, but it's quite consistently observed across cohorts. In thinking about whether or not we need to treat women with mild degrees of hypothyroidism in pregnancy, we need to think not just about the effects on obstetric outcomes, but also on the effects on the fetal brain development. And again, we know from animal models, we know from the iodine deficiency literature that the thyroid hormone is critically important for fetal brain development, probably especially in the first trimester of pregnancy. This study I'm showing is a landmark cohort study from Jim Haddo and colleagues done in the US and published in the New England Journal back in 1999. Here, they looked at children of mothers with untreated hypothyroidism in pregnancy, and it was a mix of women with overt and subclinical hypothyroidism. And they measured IQ in those children at the age of 7 years and compared IQ in the children of the hypothyroid mothers to children whose mothers had had normal thyroid function in pregnancy. What they saw is that the children of the hypothyroid mothers had an IQ on average 7 points lower than that of their peers whose mothers had had normal thyroid function. And the children of the hypothyroid mothers also at higher risk for having a low IQ, less than 85. Now, subsequent to that analysis in 1999, we've had quite a number of additional studies that have looked at this association between maternal thyroid status and child brain development. And more recently, in 2018, we have this analysis, which is a pooled individual participant level meta-analysis from 3 different European cohorts. They looked here at maternal serum TSH in association with child IQ and saw no association. But when they looked at maternal free T4, they did see associations. And interestingly, those associations are different when looking at child verbal and nonverbal IQ. So on the upper left panel here, you can see that there's a linear positive association between maternal free T4 in pregnancy and child verbal IQ. So the higher the mother's thyroid hormone, the better the child's verbal IQ scores. But there's a more complex relationship here on the upper right between maternal free T4 and child nonverbal IQ. So this does not look like a linear relationship. This seems to be an inverted U-shaped relationship, so that both mothers with low free T4 levels and also mothers with high free T4 levels have children at risk for having lower nonverbal IQ. So the key question then is, if we are fairly confident from available evidence that women with modest degrees of thyroid hypofunction in pregnancy are at increased risk for adverse obstetric outcomes and have children who may be at increased risk for developmental damage from low thyroid hormone in early pregnancy, then if we treat these women with levothyroxine, can we improve outcomes? And here is where the data get a little bit murky. I want to share with you just a handful of, I think, the most important trials. The first is this one, which comes from Faridun Azizi's group in Iran. And here they randomized women who were TPO antibody negative and had a serum TSH at baseline that ranged from 2.5 to 10. They were randomized to low-dose levothyroxine versus no therapy starting at 11 to 12 weeks gestation. The primary outcome here was preterm delivery, and they saw no improvement in preterm delivery risk in treated compared to untreated mothers. However, in sensitivity analyses, when they restricted this to only those women we would currently consider to have truly elevated TSH at baseline, those where the TSH was in the range of 4 to 10, they did see an improvement in the preterm delivery risk. Now, we have 2 studies published in the New England Journal that have looked specifically at the effects of levothyroxine treatment on child brain development. The first of these is this one. This is CATS, which was led by John Lazarus and done in the UK and in Italy. Here, they screened 22,000 pregnant women to randomize to one of 2 strategies. In the screening group, women who had a TSH in the top 2.5 percentile or a free T4 in the bottom 2.5 percentile, so effectively subclinical hypothyroidism or hypothyroxanemia, were treated with 150 micrograms of levothyroxine daily. The controls were women where blood was drawn at the same time points in gestation, but not actually measured for thyroid function until after delivery, so there would be no ethical problem with failure to treat. They wound up with 400 women in each group. They followed children of those women out to 3 years of age, where they measured IQ as the primary outcome. And they saw no difference in the IQ in the children of the treated versus the untreated women. So a negative trial, but with, I think, a couple of important caveats. The first is that randomization in this trial did not occur till 13 weeks gestation. And we think from animal studies that the first trimester is the most critical window for the effect of maternal thyroid hormone on the fetal brain. So it is possible that the intervention here was too late. The other concern, in light of the data I just showed you, showing an inverse U-shaped relationship between maternal free T4 and child nonverbal IQ, is that possibly they used a dose of levothyroxine that was just too high. They treated with 150 micrograms a day in women with very marginal thyroid hypofunction at baseline, and it is possible that they shifted women from having free T4 that was too low, made them into women with free T4 that was too high, and possibly they missed sort of that ideal range in the middle. We don't know. Subsequent to that trial, we have another big New England Journal trial, this one led by Brian Casey and performed in the US, where it was funded by the NIH. This was an even larger effort where they screened 100,000 pregnancies in order to place women into one of two parallel randomized clinical trials. In one trial, women with isolated hypothyroxanemia were randomized to low-dose levothyroxine versus placebo. And the parallel trial, women with subclinical hypothyroidism, so again, that's the TSH greater than 4 with normal free T4, again, randomized to low-dose levothyroxine versus placebo. They did this meticulously. There was virtually no loss to follow-up in either of these trials, and at 5 years of age, they measured IQ in the children, and again, saw no significant difference. So we have another similar negative trial with, I think, again, a couple of important caveats to consider. The first, again, is timing at the initiation of the thyroid hormone therapy. The median gestational age was 17 weeks at randomization. Again, if the first trimester is a critical window, they may have missed that. The second is perhaps this was underpowered. The study was powered to see 5-point IQ difference between groups. They, in fact, saw a 3-point IQ difference, which was not significant. But there's maybe a little bit of a signal of some benefit. The problem is nobody is ever going to fund a trial large enough to see a 3-point IQ difference if this is real. So we really don't know if that there's a benefit. They certainly did not demonstrate a benefit here. In this multi-center study, they also looked at basically every obstetric outcome that has ever been reported in relation to maternal thyroid status and saw no effect of levothyroxine therapy. So I think it's reasonable to say that probably treatment at 17 weeks gestation is unhelpful, but I think what we still don't really know is whether treatment earlier in gestation might have a benefit. So the American Thyroid Association is currently revising the American Thyroid Association's pregnancy guidelines. So I imagine in about 2 years, we may have some new recommendations, but currently this is what we are recommending. First, for women with a TSH greater than 10 in pregnancy, we recommend levothyroxine therapy. That is not based on pregnancy trials. Those trials haven't been done, but it's based on the fact that we would be treating those women outside the pregnancy setting regardless. And women with totally normal thyroid function, TSH less than 4 and negative TPO antibodies, there's no need to treat those patients. Women with TSH that's mildly elevated in the 4 to 10 range who also have TPO antibodies have the highest risk of obstetric adverse effects if we don't intervene, and there's a little bit of trial data suggesting benefit in that group. So we do recommend low-dose levothyroxine for those women. For the in-between groups, the women with the TSH that's 4 to 10, but the TPO antibodies are negative, or women with high normal TSH, 2.5 to 4, with positive antibodies, we do not know. We do not have any evidence of benefit in clinical trials for those groups. On the other hand, it's a low-risk intervention. We suggested considering therapy in those groups. I think most endocrinologists, myself included, do tend to treat when the TSH is greater than 4. And then finally, for isolated maternal hypothyroxanemia, currently we recommend against treatment. Right now, there aren't any trials showing benefit of intervention for that group. So there continues to be some controversy about which women need treatment with levothyroxine, but there's actually fairly good consensus on the fact that once you've decided to treat with levothyroxine, we want to make sure we're not undertreating. So the goal, if you're going to treat, is to keep that TSH less than 2.5 to just make sure you're treating adequately. And that's from both the American Thyroid Association and also from our colleagues who are obstetricians. So thinking now about hyperthyroidism in pregnancy, the opposite side of the coin here. One challenge that comes up is when hyperthyroidism is first diagnosed in the first part of pregnancy, when that HCG level is high. Recall that the normal response of the thyroid to high levels of HCG is to increase thyroid hormone production. In some women who have perhaps particularly high HCG levels or maybe particularly bioactive HCG, we can see women who don't just have a mild transient decrease in TSH, but who become frankly hyperthyroid due to the influence of that HCG on the thyroid. That will typically be worst in the early part of pregnancy when HCG levels are highest and will improve as HCG levels come down. It is also often seen in conjunction with significant nausea and vomiting because HCG is also the mediator of nausea in pregnancy. So we want to differentiate women from gestational transient thyrotoxicosis, just this HCG-mediated hyperthyroidism, from women who have Graves' disease. Graves' disease, of course, is the most common cause of hyperthyroidism in general in women of reproductive age, but in early pregnancy, GTT, gestational thyrotoxicosis, is going to be more frequent. And we want to distinguish them because we're going to treat them differently. Gestational thyrotoxicosis, we typically do not treat with anti-thyroid drugs because that is transient. It gets better as the HCG comes down, and we don't need to treat those patients with anti-thyroid drugs. But women with overt hyperthyroidism from Graves' disease do need anti-thyroid drug treatment, and so we want to know who they are. So there are a number of clinical clues we can use to differentiate between these two entities. It's unusual for there to be GTT in the absence of fairly significant nausea and vomiting. Usually patients with Graves' disease have more significant hyperthyroid symptoms than the patients with the gestational transient thyrotoxicosis. Certainly look for stigmata of Graves' disease on exam because that can tell you what we're treating. But the gold standard these days is probably to test the TSH receptor stimulating antibodies, because these days those assays are very highly sensitive and specific, and they can differentiate between these two entities if you can't do that on other clinical grounds. In a patient with Graves' disease, we then need to get peripheral thyroid hormones to differentiate between overt and subclinical hyperthyroidism, because we know from large cohorts like this one from Brian Casey that subclinical hyperthyroidism is not associated with adverse obstetric outcomes, and it can simply be monitored without treatment. We, however, need to treat women with overt Graves' hyperthyroidism in pregnancy because we know that those patients without treatment are at increased risk for having intrauterine growth restrictions, so low birth weight infants, for severe preeclampsia, preterm delivery, for pregnancy loss and stillbirth, for maternal congestive heart failure, and even for thyroid storm, often at the time of delivery. So we can't leave overt hyperthyroidism from Graves' disease untreated. The challenge is that what we know now is there's not an unequivocally safe anti-thyroid drug in the early part of gestation during organogenesis. And we have known for decades that methimazole causes birth defects. We've recognized really only in the last 9 or 10 years that PTU probably also is associated with a different set of birth defects. So these drugs can affect different organ systems in the fetus. As we first learned from the Danish registry study published in 2013, and results were effectively confirmed in a larger Korean registry study more recently, the overall risk of birth defects when these are used in the first trimester is going to be higher for methimazole. It's about 17 per 1,000 live births, additional birth defects with that treatment in the first trimester, compared to about 9 additional birth defects per 1,000 women for PTU. And unfortunately, women who are exposed to both drugs in the first trimester have children at risk for both sets of birth defects. So we need to use these with caution. And that has led to a greater reliance on preconception counseling in our patients where the Graves' disease is known before the pregnancy actually occurs. And it's important to have a very nuanced conversation with our patients who are Graves' disease patients who are women of childbearing age, so that we can sort of discuss the risks of anti-thyroid drugs in pregnancy and discuss risks and benefits of definitive therapy with either radioactive iodine or with thyroidectomy. And some women may choose definitive therapy prior to conception just to avoid any risk to the fetus of those anti-thyroid drugs. When a woman opts to continue anti-thyroid drug, or when she isn't diagnosed with the hyperthyroidism until she's already pregnant, certainly when one needs anti-thyroid drugs in pregnancy, PTU is going to be preferred in the first trimester because of the lower risk of birth defects. Whether or not we should switch back to methimazole after the first trimester, we simply do not know. There are no good data to inform that choice. In my own practice, I typically do, but we don't have a good answer to that question right now. And important to remember always in treating women with anti-thyroid drug in pregnancy, that the fetal thyroid is actually more sensitive to those medications than the maternal thyroid. So if we treat a woman with a high dose of anti-thyroid drug to really fully normalize her free T4 levels, there's a good chance we'll be making the fetus hypothyroid, which may then have adverse effects on brain development. So the target of therapy is the dose of anti-thyroid drug that will keep the maternal free T4 at or even just a little bit above the upper limit of normal, and frequent monitoring to keep it there. The fetus is at risk for hypothyroidism from the anti-thyroid drug. The fetus is also at risk for hyperthyroidism from the maternal TSH receptor stimulating antibody that can cross the placenta. And it's important to collaborate with our maternal fetal medicine colleagues who can do fetal ultrasound to help monitor for these conditions. So you can see fetal goiter in either hyper or hypothyroidism, but some more clues can be either delayed versus advanced bone age or the sustained fetal tachycardia that you can see in fetal hyperthyroidism. It is important that we do not forget why our hypothyroid patients are hypothyroid. In this slide, you can see the patient had a thyroidectomy from her scar. You can see that it was for Graves' disease from her eyes. This is her infant who unfortunately was born with Graves' hyperthyroidism. And it's important to remember that women who have had ablative therapies, so radioactive iodine treatment or thyroidectomy prior to pregnancy, those maternal antibodies, the TSH receptor stimulating antibodies, can stick around even for some years after the ablative therapy and can pose a risk of hyperthyroidism to the fetus and the neonate. So the recommendation is that in women at risk, we should be testing these antibodies in pregnancy. We do not need to test the TSH receptor stimulating antibody titers in women with known Graves' disease who are on remission or who are not requiring anti-thyroid drug. If there's not enough antibody to trigger the maternal hyperthyroidism in an intact thyroid, you don't need to worry about the fetus. But we do need to do this testing in any woman on anti-thyroid drug or with a history of that ablative therapy for Graves'. And the current strategy that's recommended, test those TSH receptor stimulating antibodies at the first antenatal visit. If they're below 3 times the upper limit of normal, which is kind of the threshold for considering them high in the beginning of pregnancy, you're fine because the levels are just going to decrease as pregnancy progresses. But if they're elevated, repeat at week 18 to 22, which is when that fetal thyroid is starting to function and can respond. Repeat again, week 30 to 34, if they're still elevated, to predict the risk for neonatal hyperthyroidism and to involve your pediatric colleagues. So I conclude by noting that it's important to use pregnancy-specific reference ranges in interpreting thyroid function tests in gestation, that overt hypothyroidism always requires treatment, but we can consider treatment of subclinical hypothyroidism depending both on the TSH level and the TPO antibody titer. In early gestation, we need to differentiate between Graves' disease and gestational thyrotoxicosis in our pregnant patients. Always, we need to consider maternal and fetal effects of therapy, and preconception counseling for any patient with thyroid dysfunction is quite critical. So with that, I will thank you for your attention.
Thank you, Prof. Elizabeth, for this excellent presentation about the management of thyroid disease in pregnancy. Please stay with us at the end. And we encourage participants to send a question. So at the end of this presentation, we can answer this question by Prof. Elizabeth. Thank you, Dr. Elizabeth. Now we'll go to the second presentation about thyroid eye disease. Very interesting subject now, because there is a new medication like anti-monoclonal antibodies like teprotumumab that used in the treatment of some cases of thyroid eye disease. It is our pleasure today to introduce the second eminent speaker, Diego Strenis. He's a professor of ophthalmology and director of chiroplastic department, University of Naples, Italy. He actually worked in Saudi Arabia for about 5 years. He was the director of continuous medical education department in King Khalid Eye Specialist Hospital in Riyadh. We welcome Prof. Diego, and I think we'll be interested. Probably now ophthalmologists, they will start this IV infusion medications. Yes, you can start, Diego. Thank you for it.
Hello, everybody. I think can you hear me? Yes. And you can also see my slide, right? Okay, it's working. The sharing of the presentation.
Yes,
So
yes.
yes, perfect. Thank you so much. Thank you for the invitation. It's a pleasure to meet my Middle East friend. I have a lot of great memory of my period at King Khaled in Riyadh, and that was so. Every time I have been involved in a meeting from Middle East, it's an honor for me, and always again make up the old memory, the old good memory coming through again. So today I'm going to talk about in general thyroid eye disease. I know that everybody knows pretty well everything, especially in this audience. I will point out some what I think might be considered some advances particularly in therapy. Just let me allow me in saying a few words about the definition. You know that there are several terms that you can find in literature, like thyroid eye disease, thyroid associated ophthalmopathy. You know that the endocrinologists in general, you like to define this disease like a Basdov orbitopathy. In general, nowadays we consider it as thyroid eye disease. It's a pretty old disease. First description maybe came out in the 12th century, and only in the 18th century, the English literature and the Dutch literature normally they played the big part, especially in the last centuries, with Robert James Graves and Karl von Basdov. They gave the name, the most used name to this disease. Honestly, I would say that there is also in Italian, but especially during the time, Italian literature was not considered so relevant to overcome the other two big names. The first description is I would say that it's a quite complete. The first description by Dr. Basdov, and he described a protrusion of the eyeball in a lady that is completely full sight. I mean, that was not severe disease, obviously, but that was the description that report the general findings that we normally have in the most, like I would say, a 70 to up to 80% of the population with this disease. The epidemiology, that is also something very important. You know that it's, epidemiology can vary, depends on the region. I always remember that when I came first in Riyadh, they told me, some of the colleagues said, but we don't have thyroid eye disease here. And maybe it's only a problem of referral. So sometimes the definition of the incidence is only a matter of referral to the center that has been considered. I think I definitely encourage people and count the incidence basic on the pub and the national registry rather than single institution, even if they are tertiary referral center. As you can see, definitely it's much more frequent in women, but in men, unfortunately, is much more severe. So although men, it's less, the incidence is less, normally men have experience much more aggressive and severe disease. By definition, thyroid eye disease is an autoimmune disease, and with a high variable natural history and broad range of clinical manifestation. It's mostly associated with Graves' hyperthyroidism. It's less frequently with hypothyroid thyroiditis. But overall, there is in general something wrong that you can detect in prior of the disease, after, during, or maybe very late on. I like to offer in my every time in my speech this microscopic view of the disease, something that I define the intermediate view of the disease, something that I say it's microscopic view, and the panoramic view. So the microscopic view is what normally explains the symptoms of the thyroid eye disease. And thyroid eye disease, a microscopic view is a mechanical discrepancy between the increased volume of the swollen orbital tissue and the fixed volume of the bony orbit. And as you can see in this slide, you see that there is a normal high on your left and the grace of ophthalmopathy thyroid eye disease on your right. You see the muscle are increasing in volume, the orbital fat may be increasing in volume. And these could explain the three phenotype that we can normally have speaking about thyroid eye disease. Type 1, that's we define muscle plus fat. As you can see here, muscle are enlarged and retroorbital fat is also increased in volume. Then we have the type 2, muscle predominant. You see, the apoptosis is mainly due to the increase in volume of the muscle. And then the third one, which is the fat predominance. Like you see, even like teeny muscle, I mean, it's not very enlarged, but you see here that the proptosis is so developed that you have a stretching of the optic nerve, which is pretty dangerous, pretty risky for the visual side, for the sight of these patients. So we generate a method to evaluate the enlargement of the fat using the MRI that we reported a few years ago. And we found that also there is a linear correspondence, a linear regression, a positive correlation with increase of volume and millimeter in terms of exophthalmos. Now we will see the intermediate view. And in intermediate view, you see that we will describe and we will discuss the histological changes. And histological changes are those one. You see that basically what if we go for the histopathology, histopath of specimens taken by patients with the thyroid eye disease, you will see lymphocyte infiltration and also deposition of hyaluronide acid and increase of the connective tissue in general with this again infiltrate of lymphocyte and increase you also from the infiltration of the lymphocyte and inflammation of the muscle. So those are the intermediate, and this might be explained by the fibroblasts and the fibroblast change that were changes that have been reported and described elegantly by Smith a long time ago, more than 10 years ago. And they found that there are some fibroblasts, THY1 negative, capable of transforming from fibroblasts to adipocytes. And this might explain why we have different population that undergo to this transformation, and those patients, they develop proptosis and all the sign of thyroid eye disease. And we have another kind of population who don't have the expression of the same fibroblasts, and they do not develop proptosis and a typical sign of features of thyroid eye disease. Then there is the microscopic view. And the microscopic view is the explanation of the pathogenesis. The pathogenesis is mainly due, quite long ago, we found in 1993 in Naples, the university where I work nowadays, that there is the expression of TSH receptor on retroorbital fibroblasts. Since then, many other reports have confirmed the presence of the TSH receptor, not very explained. I mean, we don't know why there is physiologically there is this expression of this receptor in the retroorbital fat, but indeed we have the TSH receptor, which might be stimulated by the antibody against the TSH receptor that are the same probably antibody that in some cases are the pathogenetical basis of the development of the hyperthyroidism in general, and then of the thyroid disease. Unfortunately, I would say not unfortunately, but the TSH receptor alone couldn't explain. We were not able exactly to determine how the TSH receptor exerts its action in developing the retroorbital fat changes and muscle, extraocular muscle changes. So we, the theory that at that time was incomplete, because we have that TSH receptor was almost present in all the patients with even in the normal population. So why there are some individuals who develop the disease and the other that not. So what was very helpful was that later on, the insulin growth factor receptor for the insulin growth factor 1 receptor was involved in the pathogenesis of disease. So what was found that to develop the disease, you should have the simultaneous or at least the concurrent stimulation of those two receptors. And so this one, the IGF-1 and TSH receptor, though only when these two receptors are stimulated at the same time, you can have the switching of the pre-adipocyte or the fibroblast in pre-adipocyte to adipocyte, and then the cascade of the inflammation with the TH4 maybe helper allowing B cell in transforming in plasma cell and produce antibody against these two receptors. And then the cascade with the two principal interleukin players, which are TNF alpha and IL-1, interleukin 1, that are implied in the development of the pathogenesis of these retroorbital fat changes. Here you can see in detail that we have the much more explanation and all the players of this transformation, which is that we will see in details when we'll talk about the therapy. Now, talking about the panoramic view, there are some external factors that might influence the developing of the disease. We all know that cigarette smoking is one of the main factors, particularly in patients who develop severe disease, and also patients who undergo to radioiodine treatment. They might unfortunately, they can, this treatment work like a trigger for the severe thyroid eye disease. We also were able to show a certain population, I was always impressed how that's when I published this article 10 years old, roughly 10 years ago, I found that not many people gave importance to this article. And then now is one of the most cited articles talking about thyroid eye disease. As you can see, this is the demonstration that thyroid eye disease is an actual autoimmune disease with all the trigger of the inflammation. You see this patient who developed, sorry, proptosis in one eye, in right eye. Then he was, we did the decompression in the right eye. He was doing fine for a period, but later on, you see he developed proptosis on the other eye. And then we postulate that most likely the patient, the decompression, the surgery itself worked like a trigger factor for developing the disease. Sorry. So what is new in management? We have several targets that in the last 50 years have been used to treat those patients. But it's very important to me to point out some details. One of these details is that patient must be assessed. All these patients that I'm going to show you, they are different. They are different phenotype. And it's very important. I saw in my experience, my 20 years experience dealing with the thyroid eye disease patients, that steroids have been given like water to all patients. And that is absolutely wrong. Patients should be well assessed because we defined the decision making should be based on detailed assessment, like the activity and the severity. The activity, this is the Randall curve, which is very famous and is described the thyroid eye disease over the time that tends to have a periods of worsening and then tends to have a stable. I would say I agree with one of the outstanding doctors, George Bartlett, who studied carefully this curve, and he found that the curve cannot be, this curve does not apply to all patients. So talking about the assessment, I have to say that it's very important to, we have to, first of all, to decide if you have to go for immunosuppression or for any kind of medical therapy. Sorry. It's very important that you assess the clinical activity score. And the clinical activity score, there are two main possible scale of grading. One is the one from the EUGOGO, and the other one is from the ITETS, the society that I'm the secretary. And we did a study that actually is the only study to assess the reliability of the soft tissue metrics in thyroid eye disease. So please refer to these when you have to assess your patient. And it is very important. When you assess, when you have to assess all those findings, and then you can make the score of the patient. And once you have the score, you can decide if you go for medical therapy or just watch and follow the patient for eventual progression of the disease. So chemosis is just very, very fast. Ecchymosis is the edema of the conch, and then there is the conch hyperemia. Be careful to not confound this with the cornea, with the conjunctival congestion. And then there is the eyelid hyperemia and the eyelid edema. This also, it's very important to me. Don't please, when you assess a patient, don't confound. This is the actual edema. As you can see, the skin is very tense, and not confound this with the fat prolapse, which is something like this, which is something completely. So you can see the skin crease, the folds, and this make the difference with the edema. Okay, so this is grade 0, and then pain is also very important. So once you have assessed all those signs and features, if your score is more than 4, you then go. You can assess that this patient has a mild to severe disease. Proptosis is also very important, and to study the severity, you have to test all those findings to evaluate the visual function. That is a key point to me. And when my fellows say visual acuity is good, doctor, I always say, what about color tests? What about the visual field? Those are very, very sensitive in assessing eventual optic nerve compression, which is an emergency. Patients with optic nerve compression like this, they need an urgent treatment. Also, ocular surface is very important. Corneal breakdown can have the risk, can carry the risk, or have corneal perforation, and this is also something that needs an urgent treatment with closure of the eyelid, tarsorrhaphy, and lubrication to avoid the corneal perforation. Motility, assessment of the motility is also important. As you can see, it's the squint, the diplopia is one of the problems that mainly bother the patient with thyroid eye disease. And eyelid retraction is also very important, should be assessed in millimeters, looking at the MRRD1. And finally, the fat prolapse, which is the final step when we do something for our patients, can be very severe and can also have a very, very stressful, it can be a very, very stressful experience for our patients. So now let's go and navigating a little bit the therapy. As you can see here, the trends, this is very recent article in 2020. You can see that the treatment in the United States of thyroid disease is pretty variable still. And this is because everybody use the medication more, more familiar for the physician. So every physician tends to use the medication which is pretty familiar for him. When we have mild patients with mild disease, they have few symptoms. They should be encouraged to quit smoking. Obviously, you have to wait if there is no emergency, no risk for the optic nerve of corneal exposure. It's very important that you just have to check the progression of disease, and you have to ask to the endocrinologist to refer to the endocrinologist to work on the thyroid function. Is very important. But every time I do recommend to assess the quality of life. Sometimes patients with a very little lid retraction, like this lady, for example, they might have uncomfortable life, and you should offer to them something which improve their life, which you can also like temporary treatments that eventually we can discuss later on during our discussion, open discussion. In the moderate disease, although there is no risk for visual function or risk of corneal perforation, I do recommend to bear in mind that those patients, they have a poor quality of life. As you can see here, they have problems in dealing with people. If they work, there are problems on their workplace. Sometimes it's very rare that patients are happy with their appearance. So we should do something. So normally the mainstay in Europe still is the steroid for those patients. But we all know that we have the two main problems using steroids. First of all is the recurrence rate. And we know that we cannot give forever life the steroids, because steroids can have side effects, severe side effects. So when we have a recurrence, we should look at a second option, a second line therapy eventually. And there is an evidence that about 8% of patients during the treatment with steroid can anyway develop compressive optic neuropathy. That's why all the physicians that normally deal with the thyroid eye disease, they looked in the past to find something else that might be helpful in treating those patients. Orbital radiotherapy is a very controversial point, and that's why there are some centers. I don't go in details. If you want to ask me later on, I will give you my opinion. But the main topic is the advances, and the advances in is definitely the use of immunosuppressants. I like to a little bit discuss that when we talk about immunosuppression, we normally have no specific immunosuppressant, which are pretty old and are those one. But when we use those ones that are still pretty quite famous, especially in the Central Europe, we are using just, for example, those molecules that interfere with DNA synthesis, and which means that they decrease in general the proliferation of the lymphocyte, and there is a wide immunosuppression. So patients are exposed also to infection. Particularly, we know that was difficult during this period in the last 2 years because of the pandemic of COVID-19. Normally they have so side effects, and now those molecules they have like 20 years. So in recent years we have specific antibody to treat those patients. And you can see here we have the old molecules that normally what they do, they just interfere with the replication of the T cell and B cell, and that's it. So it's like using, it's similar to use steroids. Nowadays we have those molecules, and the first one that have been used for treat thyroid eye disease is rituximab. But again, I have to say that rituximab is an anti-CD20 and resulting in depletion of B cell. So still, it's not a specific medication. It's a kind of medication which we use for several diseases, and maybe can be useful for thyroid eye disease. Unfortunately, there are conflicting results in two main studies. One was conducted in Europe, mainly in Italy, and the other one in US. And results are pretty different. In the US study, they said that rituximab is not effective in thyroid eye disease. I think that's one of the bias is underlined here, and that's in the study of the United States, the rituximab was commenced pretty late during the disease. One of the risks that I like also to underline in my talk about the use of rituximab, that's causing the depletion of the B cell. These sudden cytolysis of B cell might work like an explosion in the apex of the orbit, leading to optic neuropathy. And those is something that I report in this article in 2017. So be careful when you use rituximab in patients at risk with the compressive optic neuropathy. Tocilizumab is also quite, I would say, very widely used, very fashionable during this day. Is a monoclonal antibody, interleukin 6, IL-6. We all know that IL-6 play an important role in inflammatory cascade. Actually, it's one of the main player together with interleukin 1 and TNF alpha, particularly probably in making the chronization of the disease. Then tocilizumab had been used particularly in one of the Spain group for patients resistant to steroid-resistant thyroid eye disease patient. And the authors claim that they had a remarkable improvement in terms particularly of clinical activity score. So it makes sense. I mean, you get what you are blocking. You are blocking the inflammation, and then you get the that clinical activity score, which is the direct expression of the inflammation, which low. And eventually, because of the edema, you have a lowering of the edema, a lowering of the proptosis, a lowering of all those features, you will have improvement of the disease. That was another study published later on that with the randomized clinical trial, those patients, those authors also confirmed that the findings, the previous findings was true. But I would like to just now spend a few words to the one that is the star of this day, because as I said in talking at the beginning about the pathogenesis of the thyroid eye disease, as you can remember, we said that in order to have the development of the disease, we should have the concomitant activation of the TSH receptor here and the IGF-1 receptor on fibroblasts in order to go for myofibroblasts, maybe, so making the volume of the muscle increase, and adipocyte, which is also the other findings. I think you remember the phenotype that just have the muscle predominant, fat predominant, or mass and fat together, causing the proptosis and all the findings of the thyroid eye disease. So TPRO is an antibody that targets the insulin growth factor. And as you can see here, the pathways controlling the fibroblast activation. So there was this first study in 2017, and the news for all of us, for all the oculoplastic and orbital guys in the world, was that not only the clinical activity score that we normally can gain, also the reduction of the clinical activity score that we can gain by using the steroids or even tocilizumab, as we saw, or also we have seen, or the other immunosuppressants, as we had also using teprotumumab reduction of proptosis. This was quite remarkable achievement, I would say, and also reduction of diplopia, and there was later on another study published in 2020, which also demonstrate that particularly for active thyroid eye disease, TPRO is pretty effective in have an overall response, which is not only compared to placebo, not only in terms of clinical activity score, but is also in terms of proptosis and the diplopia and general appearance of the patient. What is very important to me, and I hope to contribute also to future papers, is the use of TPRO-tumumab for treatment of chronic thyroid disease. You know, guys, for people who have dealt with this disease for so long, such me, I think many people in the audience, we all know that the main problem are not the patients that you give the steroids and they are, or you give tocilizumab, or you give also TPRO, and they are fine. They are totally fine after the first course of treatment. Patients with thyroid eye disease that are very difficult to deal with are those patients who do not respond or recur or develop chronic thyroid eye disease. So this article, which is not a randomized study, I hope that we will be able to gain the same result in randomized controlled study and see that finally we now have molecules that maybe can be help for those unfortunate patients. Obviously, as all the immunosuppressant also, or I would say that TPRO is most, I would define the TPRO-tumumab as immunomodulator. All the immunomodulator, they have side effects. And most remarkable, I think that patients really don't like is the hearing impairment. But it seems that hearing impairment is maybe reversible, and probably if you withdraw with this medication, I think it's reversible. And so we have to see also now in phase 3, phase 4 in Europe studies to these findings that we are looking very, very carefully. A few words about severe disease. Severe disease is two types. The corneal exposure, as you can see here, and on the left, and optic nerve compression. Those are the two main problems dealing with thyroid eye disease patients, because these two problems, they can be sight threatening. Patient, I have seen in my career, patients who lost vision because of optic nerve compression not very well managed, or patients who develop severe and rapidly progressive corneal perforation and losing of the eye in 2 days. So now for severe disease, we normally give high dose steroids, but we should bear in mind that with a very high dose steroids have been reported serious adverse effects, like acute hepatic failure in patients who without HBC, hepatitis B or hepatitis C, so a regular patient, with no liver diseases, and cardiovascular thrombosis, and sudden death. And the incidence of fatality has been estimated in around 0.6%, which is pretty scary, I would say. So this also is an hope that we can maybe eventually use T-Pro also for this thyroid optic neuropathy, and particularly for compressive optic neuropathy. I have some experience also using TNF-alpha blockers. This is a patient who had double decompression. He was actually a physician who developed severe worsening of his visual function. You see that visual field was detectable only in one eye, and the other eye was pretty blind. I did the first decompression had been done in another institution. I did the second decompression, as you can see here, very wide. And although this wide decompression, you see there is no lateral wall, there is no medial wall. Although there was this wide decompression, patient every time we were trying to taper the steroid, patient dropping at division that was dropping again. So we decided to give infliximab, and he had at that time quite good improvement in terms of vision and nice recovery considering the situation from the onset. So I normally used to present this slide, but I would say that nowadays we should reconsider many of these indications. First line treatment for thyroid eye disease, maybe is my hope is to have an antibody specific, like I would say T-Pro, or maybe for not responding or patients who develop severe side effect using T-Pro-tumimab. I would say that maybe we should consider tocilizumab, because we are going to minimize and to be very, very specific in what we do in general in medicine, and particularly for thyroid eye disease. I want to show you just some example. For example, the surgical decompression that I see, you see that in the past, look at this. When I started, we used to do very aggressive decompression with the coronal approach, as you see here. And nowadays, we go for very minimal, even 3-wall decompression. Look, or even just fat decompression, like with the minimal incision, no skin incision, just swinging eyelid decompression, removal of the fat, removal of a small part of the bone, and look, very nice result in 24 hours. This is the patient the day after the decompression. So I want to conclude now, because it's too long now, my presentation. And I want to conclude saying that in surgery and in medicine, dealing with the thyroid eye disease, we need to minimize to use very minimal invasive medical and surgical treatments. And we should aim to reduce the long journey of these. I would say that some of them, they are very unfortunate patients. Just today, I did decompression for a very young and in the past beautiful lady. She's very depressed because obviously her life has been changing in only 1 year because of the thyroid eye disease. I hope you enjoy this lecture, and I await obviously your question and your observation. Thank you.
Thank you, Dr. Diego, for this excellent presentation and update about the management of thyroid eye disease. We welcome back both speakers, Dr. Elizabeth and Dr. Diego will have some questions. Actually, we have a lot of questions, but I will try to select some of them. Okay, the first question for Dr. Elizabeth. Do you use total T4 or free T4 and T3 in pregnancy? What's the practice in your center? And do you have trimester-specific range for thyroid function test?
So I wish we had trimester-specific ranges. The guidelines say we should. Almost nobody does, myself included. So one can use a free T4 in pregnancy. You need to be aware that it tends to be confounded by high thyroxine binding globulin levels in the pregnant women, and we don't have a perfect measure for free hormone. I would not use free T3 in pregnancy. I think that's present at an order of magnitude lower than the free T4 and really is confounded, and I'm not sure I trust that in the setting of pregnancy. So I would use the TSH with that caveat that it's a little bit lower in the first trimester. If you don't have pregnancy-specific ranges, use an upper limit of 4. You can use total thyroid hormone levels, 1.5 times the upper limit of the non-pregnancy reference range can work as a reference range in gestation. And for the free hormone, just be aware that we have problems with the assays. They're not perfect. If you have access to a free thyroxine index rather than a free T4, it's probably a little bit better, but I know most labs have phased that out.
Excellent. So in our practice, we'll use total or free thyroxine index?
Yeah, so I use the free thyroxine index because my lab still makes that available. And if I need to measure T3, which is less frequent, I would use the total T3.
Excellent. So what's the reference range of TSH? Does it change or the same according to the trimester?
Yeah, so it typically decreases in the first trimester when HCG is high, and then by about week 16, it's probably back up to the non-pregnancy reference range level. So it's reasonable to just use that lower limit of, I use, frankly, an upper limit of 4 throughout gestation, but to be technically correct, by the end of the second trimester, you can probably go back to the non-pregnancy upper limit for that.
So if thyroid antibodies is negative, you will accept TSH up to 4?
Correct. Correct.
Yeah, so not 3 in the past, like in the past.
Yes, they used to say 2.5 in the first trimester and 3 in trimesters 2 and 3, and that was probably based on incorrect data. When we have more data in the last decade since those guidelines were published, we think that was we made that too low, and we were over-diagnosing mild hypothyroidism, and that was inappropriate. So really, 4 is a better number.
Okay. This question may be repeated, but probably there is no enough evidence for it. Do you treat pregnant lady with high antibodies with normal thyroid function, or just you observe the patient and repeat TSH?
Yeah, great question. And one for which we don't know exactly what to do. We know that women with TPO antibody positivity who are euthyroid are at increased risk for miscarriage and premature delivery. That's pretty consistent across studies. But we now, in the last few years, have 3 trials that have explored whether levothyroxine treatment improves those outcomes, and the answer appears to be no, either when it's initiated in early pregnancy or when it's initiated preconception. So right now, although the ATA guideline in 2017 suggested consideration of low-dose levothyroxine in these euthyroid TPO antibody-positive patients, I am not doing that anymore. I think we'll probably take that out of the next guideline. What those patients do need, though, as you noted, is observation, because they are at higher risk for developing hypothyroidism as pregnancy progresses. And recommendations are to monitor the TSH fairly closely in the first half of pregnancy, just so that if the TSH does become increased, that you'll catch it and can treat.
Excellent. Dr. Diego, do you have a score for endocrinologist or for general practitioner when to refer patient with thyroid eye disease? There is simple score, because we know that as endocrinologists or other subspecialties, they are not familiar with the management of thyroid eye disease like ophthalmologists. So scoring system or...
Thank you for the question. That's what I mean. The time was a little bit short, but was I'm trying every time I'm trying to show those slides because I think that it's very easy also for the endocrinologists to learn how to assess, because it refers to the general sign of the inflammation. You have rubor in Latin, which is redness. And if you have redness of the conch of the or of the eye, you can just say +1, +1. If you see tumor, which is the second Latin from the Latin term of for the inflammation, edema. Okay, tumor is edema, and you have edema of the conch. You can see it looks like a drop. and or edema of the eyelid, as I showed, the skin is very tense. And then you can see is +1, +1. So, and you just ask the patient, do you have pain? Dolor in Latin. Pain, do you have pain? Pain at rest, or something like you feel like a pressure in the back of your eyes, behind your eyes. And so if say, yes, it's a pain. So you generally have you can have roughly an idea. And if there is an inflammation, and we are all doctors, we are not endocrinologists or ophthalmologists, we are doctors, we are physicians, sorry. We are physicians. We know that if you have inflammation, then you can think that maybe this patient, even as endocrinologist, maybe this patient needs modulation of the inflammation.
Okay, thank you. What's the dose of steroid and the mood of giving steroid in thyroid eye disease, or significant thyroid eye disease, or active eye thyroid disease?
I have to say that I stopped long time ago giving oral steroid. I'm not in favor of the oral steroid. I know that even when I've been in Saudi Arabia, it's easy sometimes because people comes from a remote region and you cannot IV steroids. It's better to give IV steroids like 500 milligrams of methylprednisolone. I normally give the 10 milligrams roughly per kilo. And I think high IV steroids are definitely much better than oral steroid. If you have a patient that cannot come every week, because normally I give 500 average, 500 IV steroids every week for 6 weeks. And then I tapered for other 6 weeks to 250 milligrams. And then I tapered only with the 5 milligram and with oral. But if you, I prefer to, I do prefer to give the IV steroid in hospital setting or in the day, obviously in a daycare setting, but not at home because of the side effect, acute side effect. But overall, the side effect of the IV are much less than oral steroid giving when you use a long course of oral steroid. And oral steroid not only give more side effects, but also are there are many articles published in literature which demonstrate that are less effective than IV. So definitely, if you want to go for steroid, and if you can have your patient in the hospital for just a couple of hours a day in the hospital, just go for IV steroid.
Excellent. Dr. Elizabeth, one simple question maybe, because we have some GB family medicine with us. If a pregnant lady, we increase the dose of thyroxine, after pregnancy, we return to the pre-pregnancy dose, or we decrease the dose by 25%? I think pre-pregnancy, isn't it?
Yeah, so thank you also for the reminder that it's important to remember that most pregnant women are going to need that dose increase in pregnancy to maintain euthyroidism, even if they have perfectly beautiful TSHs on their levothyroxine before pregnancy starts. So we recommend an empiric increase in levothyroxine of 25 to 30% as soon as a woman's pregnant, monitoring of TSH every 4 weeks in early pregnancy till about mid-gestation to make sure that TSH is under the goal of 2.5. And then at the time of delivery, typically requirements go back to baseline. They're largely driven by increased thyroxine binding globulin levels and by higher metabolism rates of thyroid hormone in pregnancy because of deiodinases in the placenta. So it's fine to go back to the pre-pregnancy dose at the time of delivery and then check a TSH level about 6 weeks postpartum to make sure it's still at goal.
Excellent. So in pregnancy, we measure TSH every 4 weeks, isn't it? And
yep, every 4 weeks we say till week 16.
Every 4 weeks during the first trimester and second trimester?
Yep, and then at the end, sort of late second or early third trimester, check again.
Okay. Regarding iodine deficiency in pregnancy, we know it is not routinely we measure it. in the urine, for example. So patient has high TSH and antibodies negative. Do you think this causes iodine deficiency? And how we treat? Do you give prophylaxis and for all pregnant lady iodine without thyroid disease or not? What's about patient with thyroid disease? Do you give them supplementation or not?
Okay, a lot in that question. You've given me a lot to chew on. So the first thing is that we don't have an individual biomarker for iodine sufficiency. So we cannot, for example, get a urinary iodine concentration and know if our patient is iodine deficient or not. It's a population biomarker because individual levels are very, very variable. So one thing to know, but for wherever you practice, you want to know what the iodine status is for that population. The Iodine Global Network website has maps globally that can tell you that, give you the local most recent information for that. And in any part of the world where we know there is a problem with iodine deficiency in pregnancy, because pregnant women need more iodine than the rest of the adults, and that's true in the US, it's true in a lot of Western Europe, the recommendation is that we should just give every pregnant woman a daily supplement that contains 150 micrograms of iodine to make sure she is getting enough. I would not assume that a woman with a high TSH in pregnancy and negative antibodies is hypothyroid because of iodine deficiency. You cannot make that assessment, and I would treat with levothyroxine.
How we confirm diagnosis of iodine deficiency in pregnancy?
You really can't because there's not an individual biomarker. So you can know if the woman is coming from a part of the world where there's iodine deficiency. You can know in your own part of the world what the key sources of iodine are, and they are likely to be iodized salt is a key one, but in the US, it's also dairy and seafood. And you can inquire about intakes of those foods. But again, because we don't have a validated individual biomarker, we can only really assess iodine status of populations, not of the patient in your office.
Okay. If a pregnant lady has a Graves' disease and controlled in 10 milligram carbimazole, and they mentioned the free T422 TSH 0.01, is it better to stop antithyroid for the first 2 weeks and restart later on if the is still abnormal? I think we don't depend on TSH in pregnancy. Probably this is what they mean. So what's your opinion regarding if the patient already?
And your free T4 measurements are different from what I'm used to because we don't use the SI measurements in the US. But again, as you said, we target therapy in pregnancy to the free T4, not to the TSH, because often in Graves' disease, that TSH stays low. There's a lag once you normalize the thyroid hormone, and you don't want to overtreat with anti-thyroid drug in pregnancy. In a patient who is on a low dose of anti-thyroid drug coming into pregnancy, typically who seems like they're effectively already in remission on that low dose of anti-thyroid drug, we had suggested a strategy of stopping anti-thyroid drug as soon as they know they're pregnant to minimize the teratogenicity of the anti-thyroid drug, to monitor thyroid hormone very carefully, and to restart immediately if they become overtly hyperthyroid. I'm not sure I would do that in the particular case you suggested where the TSH is still suppressed, because in my experience, often by the time they're really in remission, the TSH is normalized, and I would anticipate that that patient might be at risk for developing overt hypothyroidism if we withdraw drug, and we know that that's not safe in pregnancy. But in a patient where you're really fairly confident, there's no big goiter, the TSH is normalized, the TSH receptor stimulating antibody levels have normalized, and they only need a low dose of anti-thyroid drug to keep them euthyroid, one can consider that stopping immediately with pregnancy and monitoring closely.
So in a pregnancy or non-pregnancy, will not depend on TSH because it take time to come up, isn't it?
Yep.
And will depend on free T4 and T3. How frequently you will measure free T4 in a pregnancy?
How often to monitor that in Graves' disease?
Yeah, with Graves' disease, yeah.
Yeah, it depends a little bit on the patient and how acute this is and how long they've had it. But I think it's reasonable if you're stopping the anti-thyroid drug to even measure every week or two until you get a sense of what's happening. But in routine patients where you're treating them, probably every 2 to 4 weeks measuring the thyroid function tests is reasonable, because we really want to be able to titrate anti-thyroid drug dose pretty carefully to keep the free T4 at goal.
Okay. The other question for Dr. Diego. Is Graves' eye disease is reversible?
Is the Graves' disease, sorry?
When patient come with you with the Graves' disease, is it reversible, remit by itself, or depend on the thyroid function? Maybe also Dr. Elizabeth will elaborate.
There are two very elegant studies that I do recommend about the self-resolution of the thyroid eye disease. So it apparently, when we use, for example, steroids, it's patients who respond to steroid are those patients that eventually they improve by themselves in a longer time. So the steroids, maybe the theory is the steroids only accelerate a spontaneous improvement. So there is a wide population which was calculated by around 50% that has a spontaneous and resolution of disease over the time. And the time was evaluated within 5 years. So that is the evidence so far.
The other question, Dr. Diego, what's the indication for antimonoclonal like Tibra or Tobromamab? What's the indication and what's the dose and the duration of the treatment?
So in United States nowadays is considered, is approved as first-line treatment. In Europe, and I assume also in Middle East, in many other countries, is not yet approved as first-line medication because there are many studies going on. But I would say that if all data are confirmed, I think that if we have side effects that are well controlled with like withdrawal of the medication in case of hearing loss or hearing impairment, impairment, I would say that TPRO might be considered a first-line treatment because not only as the steroids and tocilizumab, for example, lower the inflammatory cascade. Apparently, it's an immunomodulation which might prevent the switching of the fibroblast in the pre-adipocyte and adipocytes later on.
Excellent. So how many infusion you will give and for how long the duration?
That is really under, I mean, under, I mean, we are studying that. Some patients, they go pretty well with the few infusion at the beginning. Some patients need refuel the infusion after 6 months or 1 year because of the recurrence of the disease. So this is, I think, a future study they will give the actual answer, how many dose a patient need. I think that we will have dose for, I mean, 3 or 6 dose for patients with the mild disease. And I think severe disease, patient with severe disease, they need longer treatments.
Okay, thank you very much. Dr. Elizabeth, do you treat isolated maternal hypothyroxemia? We know that free T4 is not reliable in a pregnancy, and as you mentioned, you use free thyroxine index or total T4, and there is calculation for it depending on how many weeks of pregnancy. So, any indication to treat isolated maternal hypothyroxemia?
Yeah, right now the answer is no, but I think that's something that might change going forward. We have good evidence that the isolated maternal hypothyroxemia does seem to be linked to some adverse obstetric outcomes and certainly to poorer child developmental outcomes. We don't have any trials showing benefit right now of treatment for that isolated maternal hypothyroxemia. The 2 major trials in the New England Journal were both negative, although, as I told you, that we have some concerns about the methodology in both of those trials. And then, as you point out, it's also challenging because we've got flaws with the assays, and it's hard to know what a truly normal free T4 is in your population in your assay. So it would be very hard to know clinically right now what that threshold would be for initiating treatment or the target of therapy. So I think right now the answer is probably we should not treat, but I think this is something that needs further study.
Excellent. So we can summarize the difference between gestational thyrotoxicosis and Graves. What's the most important one of them? Is, for example, history of repeated vomiting indicate GDT or gestational thyrotoxicosis? Because you said there is no vomiting in Graves' disease.
Right, and sorry, I had a little trouble. For some reason, the sound just cut out. I'm sorry, but could you repeat?
The difference between gestational thyrotoxicosis and Graves. What's the most important one? The parameters?
For differentiating. Yeah, probably. I mean, if you've got somebody with a big goiter with a Brui or Graves' eye disease, you don't need any other testing. You know what that patient has. You know it's Graves' disease. But if you don't have very clear clinical grounds, the TSH receptor antibody titer, again, is very sensitive and specific. So I think that's the best way to differentiate if it's not sort of obvious from the clinical exam.
Excellent.
Dr. Nasser, may I specify something? Maybe in the question that you asked me before, I mentioned how many, I didn't mention the approved dose so far for T-Pro, which is one infusion every 3 weeks, and for so far maximum of 8 infusion, which means 2 years. So that is the, maybe I missed this when you asked me how many doses. That is the FDA approved. This is the FDA approved regimen.
Thank you very much. Dr. Elizabeth, does total thyroidectomy in Graves' ophthalmopathy help in reducing TSH receptor antibodies and help in reducing the severity of Graves' ophthalmopathy?
I'm so sorry. I'm suddenly having trouble with the audio. I can't say that again.
Did total thyroidectomy will improve Graves' ophthalmopathy and decrease the severity of Graves' ophthalmopathy? Total thyroidectomy.
Yes, often it does. So thyroidectomy we often consider in patients with severe ophthalmopathy, in addition to all of the treatments that Professor Stranese has discussed, because presumably you're decreasing the drive for the antibody production. So that would be one of the advantages of considering thyroidectomy before pregnancy. You know, one of the additional reasons to consider it is in that patient who has some Graves' eye disease.
So will improve ophthalmopathy?
Will it improve ophthalmopathy? Not quickly, not as quickly as teprotumumab, but it probably does over time.
I can add something. I think that normally, sorry, Elizabeth. So the thyroidectomy, maybe in the long term, definitely it helps in improving thyroid eye disease.
But not necessarily in very short term.
Yeah, and in the short term, on the other end, on contrary, you should be careful because
it can worsen it transiently.
It's worsening, yes. It's worsening because of the spreading of the antigen and with the manipulation of the surgery itself. As the guy that I show with the decompression that developed thyroid eye disease on the other eye, on the contralateral eye. And that's it same apply for the manipulation of the thyroidectomy. So you're spreading the antigen and maybe increase the immune response, and in the short terms might make worse the thyroid eye disease.
Okay, I think we take longer than time, but I found it interesting to continue. We'll stop here. I want to thank Prof. Elizabeth, Prof. Diego. I want to thank all participants actually, and really they will add a lot of value to the Arab Thyroid Association. We'll not forget the sponsor Horizon and also our organizing company ICO. So thank you very much. Will be CME hours for this from Dubai Health Authority, and you will receive email that will require evaluation. Then you will receive your certificate within a few weeks. Thank you very much. Thank you all.
Thank you. Thank you for the invitation. Thank you for joining.
Take care.